welcome. It looks like we have about 75 people who have joined us so far, and the number's going up, so that might go up in the next few minutes. But for those of you guys who have tuned in for these webinars in the last few weeks, I'm Dr. Tano. I'm one of the primary care doctors at Rockville Internal Medicine, and I have been coordinating some of these lectures. So I know I got some feedback here. Patient said, I've been in withdrawal mode since the abundance of webinars last week's. I encourage Dr. Tannenholz to encourage more practitioners to add to the list of topics. I absolutely love these. So thank you for those of you who are giving us good feedback. That gives us a lot of encouragement to continue. Today we have a special talk. I'll come back to introductions a little bit more, but today's a dermatology talk. Just to plug next week's talks. On Friday, Dr. McConnon is a sleep doctor. He's going to talk about insomnia and COVID. So that'll be an interesting talk, especially if you've had troubles with insomnia now or ever. I mean, who hasn't had trouble with insomnia? And then next week, the email should go out either today or tomorrow from Privia for links for next week. We do have Monday, Wednesday, Friday scheduled. Monday is going to be another COVID update with Dr. Tannenholz and Christina Schrack, our nurse practitioner. They're two members of our COVID task force who have been doing a really good job of keeping the practice up to date and things running. So tune in for that. I know our first COVID update was very popular, so that's going to be Monday, same time. Wednesday, we're going to have an update from one of our nurse practitioners, Teferi. She's going to talk about cholesterol, high cholesterol, and some treatment options. And then next Friday is going to be another lecture from a combination of people, Dr. Shashir Ketan, who's one of our internists, and then two of our newest internists, Dr. Council and Dr. Holmes. So so the talk is going to be on specifically on virtual visits and some of the, getting through the kinks and how to go about it and how to prepare for one and how to get the most out of a virtual visit, since that's what we're doing and probably will continue to do for at least another couple of weeks. But also, if you have a doctor who has left the practice, so I know like Dr. Kellogg retired a few years ago, and then some of the other doctors have changed their schedules. Dr. Sterowitz is now concierge. Dr. Liu has been out of the office on medical leave, and then Dr. Silverman is retiring in the fall. So if you are a patient affected by one of those doctors leaving, then also next Friday's lecture, even though it's on virtual visits, it might be a good idea to tune in and see the two of the new doctors and see if you think you might be a good match with one of their personalities. So that's coming up, and then we're updating these as we go. I'm trying to get all the doctors to get involved and do whatever talk they like to give. But if you have specific, requests or something, feel free to let us know, and we can try to accommodate if we get somebody to talk about it. So today's talk is on identifying some common findings of skin cancer. It is given by one of our two wonderful dermatologists, Dr. Sara Brooks. Sara is doing all virtual visits at this point, I believe, or Dr. Brooks, maybe you can speak to that, because dermatology sometimes can be hard to do over virtual, but I'll let her get started. And then she requested that if you have questions to get going, you can go ahead and submit them and then try to make this a little bit more interactive. But any questions that we don't get to during the talk, I'll try to get to at the end if we have time. So you, Dr. Brooks, take it away. Teach us about skin cancer.
Sure. So just to touch on your question about virtual visits. So what I'm doing is seeing patients virtually. I'll screen everybody virtually. And then if someone is needing to come in the office, I will come in the office to see them. Usually I'll come in on a Wednesday. So if someone has a spot that I screen and I'm like, I really can't tell, I'm a little worried about this being a skin cancer, or like you have a bad rash, I want to keep people out of the ER. So I am seeing patients, I will schedule people in the office as needed. Okay. So, all right. So I don't really have a lecture today, but I did sort of want to go over, skin cancer and screening, how we do it, what we're looking for. So a skin cancer screen is when you come into the office and we take a look at you from head to toe. We'll ask you basically to take clothes off. I leave underwear on and look under the underwear. And we look you all over because skin is everywhere, between the fingers, fingernails, armpits, groin, feet, between the toes, and in the scalp, under the hair. So we look at everything. When we talk about risk factors for skin cancer, and there are the three most common kinds of skin cancer, which is basal cell, squamous cell, and melanoma. All three of those have in common in that they're caused in some way, shape, or form by ultraviolet light. There's also other rarer forms of skin cancer, which don't really have so much to do with the sun, including Merkel cell carcinoma, cutaneous T-cell lymphoma, sebaceous carcinomas, and dermatofibroma, DFSP, dermatofibroma sarcoma protuberans, which I'm not going to touch on those today because those are a whole different set of things. So what we're going to ask you when you come in to get an assessment of risk for skin cancer and prior sun exposure is going to be whether you have a history of blistering sunburns, and I don't just mean like peeling, I mean like blisters, like water bubbles. Tanning, if you've ever been to a tanning booth, going to a tanning booth 2 times in your lifetime increases your risk of melanoma by 75%. So tanning booths, where you grew up. So the age in which you spent your younger formative years when you're outside a lot is an independent risk factor for skin cancer. So, if you grew up near the equator or you grew up in Sweden, and that's gonna affect your lifetime risk. Family history. So any first degree relatives, meaning mom, dad, sister, brother, with melanoma, or basal and squamous, but melanoma is a big one. And if you do have a family history of melanoma and in a first degree relative, I also do ask about pancreatic cancer because they do tend to run in families together as in the same gene, same gene mutation. So family history, and obviously if you've ever had any skin cancers in the past. I like the website, by the way, the one that I have up here, which is American Academy of Dermatology. And they have a public area which they talk about skin cancer, and they have a video, and they actually tell you how to perform a skin self-exam, which I'll kind of go through here. So, and this is what I do to you when you come in, but this is what you're also doing to yourself, or should be doing to yourself, every few months when you're trying to check your own spots. So basal cell is the first kind of skin cancer. That's the quote unquote best. And we call that the best because it doesn't spread to other organs generally, although very rare cases it can. That is going to be a pink bump. So this is a picture of a basal cell. It's called a nodular basal cell. There are different kinds of subtypes of basal cells. And depending on the subtype of basal cell, it affects the treatment, and also the location affects the treatment. So, but what you're looking for in terms of basals is a pink bump that can grow over a period of months to several years. Sometimes they're extremely slow growing. Sometimes they can be more fast growing, but a lot of times they grow really slowly. A pink bump that grows over months and can bleed. Bleeding is a big symptom of them. Sometimes they can itch, sometimes they can tingle or burn. They can sometimes have a sensation. Sometimes they'll just be totally asymptomatic. So And again, these grow over a period of years. And sometimes, these things, they will get better. Like your body's immune system will fight them. It will get better. And then you're like, oh, maybe it's gone away, but then it comes back. And that's sometimes, people will come to my office and they'll come in the office and they'll say, okay, this spot was here, but it kind of got better. So sometimes it's hard to tell, and you kind of have to, I see you as a snapshot of like 1 second in time. And then, so if something, if I don't see something on one day and it comes back the next day, I want people to let me know, because sometimes they can kind of wax and wane in intensity.
Hey, Sarah, we have a question here. If you could address what this might look like in a darker skinned person.
Sure. So basal cells, so 1 out of 5 white adults will get a basal cell in their lifetime. The darker your skin tone is, the decreased likelihood, but that doesn't mean that it doesn't happen, because it does. So if people with darker skin tones have been, and I'm talking, like tan at baseline to darker than, a little bit darker than that. We call that the Fitzpatrick skin type, but they won't be, I can see redness in darker skin tones, but that's because my eyes are trained to see it. So it's going to be like a little bit darker than the surrounding skin, and the skin will have a quality of what we call a pearliness. So if you'd would shine a light on the side, it would look sort of like shiny, not dull, like kind of normal skin look if you shine a light on it because of the surface defects. These will be more like smooth, and they will still bleed in darker skin tones. They will bleed. They will get ulcerated, and they will again change and get bigger over time. So they will have a red quality to them. It will just be a little, the background skin will be a little bit darker. And there's a subtype of basal cell called pigmented basal, which, if you see this one in here, these little, that's not actually blood, that's pigment. So not all basal cells have some pigment in it. So darker skin tones will have more pigmented basal. Eleanor?
Yeah, that's great.
All right. It's kind of bizarre because I don't see anyone. I'm just sitting here talking to myself. All right, so basal. All right, so unless anybody has any other questions about a basal, move on.
Maybe just mention where these are most commonly found on the body, because they grow somewhere.
Sure. So most common are head and neck, and arms. So the main risk factor for basal cells is long-term chronic, basically intermittent high intensity sun exposure. So every year you go to Florida and you get fried. That's a risk factor for basals, as well as melanoma. That is melanoma's main risk factor, is basically high intensity intermittent sun exposure. Whereas something like squamous cell is more of a chronic long-term, like I'm outside all the time, I'm a gardener, farm, that kind of thing, squamous cell. But anyway, to answer your question, head and neck, arms, also upper back, anywhere where you have high levels of burn potentially. So those are the most common sites. And let me just say that, when you're looking at yourself at home, so I would make sure that you have a big full length mirror and a nice big handheld mirror to take a look at yourself. Okay. So what you do is examine your front of your body, like in the picture here, and the back. Okay. you want to look at yourself with your arms up, so under the armpit and on the sides here. Make sure you look at forearms, elbows, palms between the hands. Make sure that you're looking without fingernail polish on. That's another thing that would be good if you have a dermatology appointment, is to take your fingernail polish off or toenail polish off beforehand so that we can get a good look. There are skin cancers, melanoma, squamous cell that can occur under the fingernail and toenail beds, between fingers, between toes. And in fact, I've seen a basal cell on the bottom of a foot. So that's very rare, of course, but it definitely can happen. So when you're looking at yourself, make sure you look everywhere here. Remove your underwear. Look between the legs, between the labia, between the buttocks as well as you can. Use a hand mirror to look at the back of your neck and your back. Like kind of, you can triangulate yourself there, and make sure that you look on the bottom of your feet too. So that's kind of how to do a skin check on yourself between your appointments. And not everybody needs a full skin check all the time, or I'd be doing that forever. But with those things that I had mentioned, those risk factors, do you have history of blistering, tanning booth usage, family history of squamous cell melanoma or basal, if you high intensity sun exposure, and or like area where you spent your childhood. So those are things that, I'd say that you probably are due for a skin check. It would be a good idea to get a baseline skin check. All right. So next is the next type of skin cancer. Eleanor, is there any questions?
There is a question here, but I think you might want to save it to the end because it's maybe a little non-specific, but is a white discoloration on skin a sign of anything to worry about?
Certainly. So there are whitish discolorations that could be vitiligo, but that's a disorder where you get depigmentation of the skin. Some people, there's a condition called idiopathic guttate hypomelanosis, which means little white spots and we don't know why they happen. But they're like inverse freckles. They're kind of like sun related. And those can look like little white spots. They kind of look like confetti was just thrown on your skin. And those have no concern. Those just are what they are. But certainly other things can have white spots on the skin, like in sclerosis. So, if you're concerned about it, certainly that would be a good thing. That would actually be a good virtual visit. Actually, I wanted to touch on what is a good thing for a virtual visit. Is that okay if I just break off into that for a sec?
Great.
So skin checks, like full body skin checks without any particular complaints, not probably the best use of a virtual visit. However, if you have a complaint of, meaning if you're worried about a spot, if you're like, the spot is kind of changing, I don't know, that's a great virtual visit. And I can say, okay, I'll look at that, look at that one spot. And sometimes I'll say, it's really hard for me to tell on this virtual visit. I think, we should wait until this is over, or B, I'm actually kind of concerned that it is cancer, and I need to see you now. So there are guidelines put out by our academy for who needs to be seen at this point in time. And, if you're worried about a skin cancer, we go into the office to see you. That's important. We don't want you to wait until this whole thing is over, when and if that happens. God, please, I hope it ends soon. So that's a great use of a virtual visit, is if you're worried about a spot. Another great use of a virtual visit is acne. Acne is perfect. And now if you guys know anybody or kids who are home from school, whatever, this is actually a great time. And especially because half of my schedule is gone now because I do a lot of skin checks. My schedule's open, so happy to see you. I'm actually bored here teaching my children, so please come on in. So acne and rashes. Like I don't want people to go to the emergency room or go to an urgent care. A lot of times I can hear a history of a rash without even seeing the rash, and I know what the rash is because I've just heard it so many times. So rashes are a great virtual visit. And also I can say, oh, this rash is horrible. I'm worried about something very bad. And you come in the office, we do a biopsy. But if it's not, great, we can take care of it on a virtual visit. Just a FYI about virtual visits there. All right. So yeah, next kind of skin cancer is squamous cell. That's the second worst kind of skin cancer. And we call it the second worst because it can spread to other organs, meaning metastasize. Especially the ones on the head and neck are more prone to metastasizing. So those should be treated a little more aggressively. The ones on the arms and legs tend to be a little less aggressive and don't spread quite as much as the ones on the head and neck. What squamous cell is going to be a scaly, crusty bump that, again, these tend to grow a little bit faster than basal cells. They I don't know what happened to my squamous cell thing that was up here. I'll get you off of my screen sharing and put that back up in 1 second. So that's going to be a scaly or crusty bump that it grows a little bit faster than basal cells. And in fact, a lot of them tend to grow rapidly over like the course of weeks. And they do tend to, more than basals, hurt or itch as they're growing because squamous cells do invade nerves. So they can be more symptomatic. The precursor lesion to a squamous cell is an actinic keratoses. So I always talk about keratoses, and there's two kinds of keratoses. There's the actinic keratosis, which is the precancerous kind, okay? And they are precancerous in that about 5%, 1 to 5% of them can turn into a squamous cell. That's not very high when you have one actinic, but many times people will have their whole scalp is covered with actinic keratoses. So that's like thousands of 1 to 5% out of 1,000, much higher than 1 to 5% out of one actinic keratosis. So the more sun damage you have, the more risk of having a squamous cell. Most common location, head and neck, back, arms, lower legs, areas where people get a lot of they sit on the beach, umbrella covers everything about their lower legs. And yeah, so crusty bump that grows over months, can bleed, hurts, itches. And then I was going to say about the keratoses, then there's the other kind of keratoses, the seborrheic keratoses, which are the benign kind. And actually, those can sometimes mimic squamous cell carcinomas because they can grow rapidly. They can get irritated, red, and crusty. They will change very quickly. And they can also simulate melanomas because they can be very, very dark. So again, something that we'd want to see you for if something was changing. I love when people come to see me and they're like, oh, this thing is changing. And I'm like, yeah, it's just a seborrheic keratosis. It's fine. It's nothing to worry about. But so if something's changing, that means I'd want to see you and at least get it. So that's squamous cell. Any questions about squamous cell?
Dr. Brooks, do you think you could take a moment just to pull up some photos?
Yeah. Yes.
Squamous cell and actinic keratosis and seborrheic keratosis too.
Yeah.
Maybe a lot of probably what you do during a skin check is treating the precursor cancers, the actinic keratosis. Maybe talk a little bit about how you guys do that, because I'm sure you do a fair amount of that.
See, actinic keratoses are they're actually, you can't really see them. I will try to pick a picture of one, but they're more, you feel them rather than see them. Okay, let me, sorry, I just put myself off screen share. So this is a picture of a typical actinic keratosis. This is more of a hypertrophic actinic keratosis, meaning it's thicker and it has more substance to it, but still probably actinic. And you can see where I have my mouse over here. These are other actinic keratoses. And I guarantee if I felt that, it would have some like sandpapery type feel, and here as well. Usually what I do.
And these are the pre-cancers, right?
Pre-cancerous stuff. Yeah, these are pre-cancerous. Yeah. And so if you have like individual discrete ones, I freeze them with liquid nitrogen. They get red, they get crusty, then it goes away, leaves a little bit of redness where we do it, and then that slowly fades over time. The other way to treat it, so that's lesional directed therapy, and then there's what we call field therapy, meaning we treat not only what we see, but we know that there's underneath there a lot more going on. So we treat the whole area, and that can be done one of a few ways. It can be done with something called blue light, which is where or photodynamic therapy, which is where we take a photo activator, put it on the area, let you sit for about an hour, then put you under a light. And that is one way to treat them. Then there's also topical therapy, which is a cream called, there's various creams, but one is, they're all a variation of fluorouracil, or there's something called Aldera, which is a imiquimod. They have varying application schedules, but in the end, what happens is you get your skin gets angry because all of these precancers are dying, and gets crusty and red and irritated, and then but in the end, after it's all said and done, your skin is smooth like a baby's butt, and no more skin cancers there, no more pre-cancers there. So that is the way to treat them. The topical therapies are a little more effective than the blue light therapy, but the blue light is less painful and has a shorter duration of like crusting and oozing than the topical treatments. The topicals are sometimes hard to tolerate. So now is a great time to do those kind of topical treatments because nobody's going anywhere. So that's actinic keratoses. Now, so pre-cancer squamous cell is the next. This is a classic squamous cell. So kind of red, crusty, plaque, looks like probably on a temple or something like that. And those, again, they can grow anywhere from slowly to super fast. And I had just Googled the image here, but there's a one subtype of a squamous cell that grows extremely quickly. It's called a keratoacanthoma. And I guess I sort of down here on this one right here. I'm not going to click on it because I don't know where that leads me, but the one that I've got circled right down here, it just looks like it's got like a little keratin, nice rusty volcano in the middle. And so that's the kind that grows very rapidly. The good news about those is those are actually not aggressive at all. And in fact, if you leave them alone, they will usually self-involute. But they look so scary under the microscope that everyone treats them just like a squamous cell. Okay, so now seborrheic keratoses, which is totally benign, not cancerous, not going to do anything to you. This is a very classic seborrheic keratosis right here. These are, they almost kind of look like those puffy stickers. You could just like stick it on and like peel it off. And in fact, people do peel these off because they don't like them. I don't recommend it, but we can freeze it, and they do peel off a little bit easier than just ripping them off. But yeah, this is one example, and you know, there's many ways that a seborrheic keratosis can look, and I try to say like there's different flavors of ice cream, but it's all ice cream. There's different flavors of seborrheic keratoses, but they're all seborrheic keratoses. So some are pink, some are very dark like this, some are super crusty, some are more flat. They have varying presentations to them, but this is like the classic textbook seborrheic keratoses. So.
And I could say, as a primary care doctor, I get questions about these all the time. People tend to have many of them rather than just one. And you know, usually they have a lot. I send them to a dermatologist just for a skin check because I don't want something else to be hiding among them. But they can usually be left alone. Sometimes I have patients who they get caught in their, you know, they're on their bra strap, so they want it removed, or it's on their neck or somewhere they just don't like the way they look, and then Dr. Brooks or Dr. Sara or other dermatologists can just take them off. But sometimes we call these like age barnacles as a, you know, term, but these are very common. So I know that photo just has two, but usually it seems like when people
they have like, you know, like this guy's got plenty on his back for sure. Yeah, I mean, people who have tons of them, I will also, yeah, freeze, especially if they're real dark ones, I will freeze them because, yeah, to clear the, you know, clear the weeds, you know, so to speak, so I can actually focus on things that matter. Like, if, you know, if you've got hundreds of seborrheic keratoses, sometimes it makes it hard to see a melanoma. And these actually have nothing to do with sun exposure. These are not sun related. So these will happen with or without sun exposure. Yeah. Any questions?
no questions at the moment.
All right. So so the next one is melanoma. So melanoma is the bad kind of skin cancer. Melanoma is the kind that can spread to other organs. The way we think about telling people to look for melanoma is the following. Okay, so this is actually something on the AAD website, which if you go to aad.org/public, it has all this stuff here. And so we talk about the ABCD. So A. So A is for asymmetry. Does one side look like the other? Okay. So if you take this example here on the little infographic thing, this is like what
can you actually, is there a way to like zoom in on that? That's pretty tiny on the screen.
Oh, okay. Sorry.
Okay. You just zoom in on, I don't know if you just zoom in on your screen, but.
Is that better?
It's a little better, but it's still pretty small.
I just.
Oh, there. Oh, that's.
There we go. Okay. So asymmetrical. Okay. Does one half look like the other? All right. We like things that are nice and symmetric, not something that has like this sort of jut off to the side here. Okay. Let me show you something that is symmetrical. So this is a compound nevus, which is just a benign mole. And a lot of times people say, oh, it's raised, it's not okay. Actually, most things that are raised are okay. There are nodular melanomas, and those are not good. So that doesn't mean, that's not a universal rule, but a lot of times people will say, oh, I have had this mole forever and it's starting to get more raised. And that's actually, moles have lives just like we do. And so sometimes, you have a beauty mark on the face. It's flat when you're younger. As you get older, it sort of, it becomes more dome shaped. And then as you get older, it becomes even more dome shaped and sort of like more floppy, and like you can sort of wiggle it, and it'll lose its color actually. So that's normal. So anyway, this is a nevus that is symmetric. Okay, these are junctional nevi, meaning they're at the junction of the dermis and epidermis, and those are flat, and those are symmetric. Okay, so B is for border. Are the borders nice, round, and regular, which we like. We don't like anything that is irregular. Okay, and you can see that border is irregular. That's not a nice round shape. It's got like scalloped edges. You kind of really can't see where like the normal skin starts and that lesion ends. So and you can see these borders are nice and smooth. Okay. So color. We like things that are a nice uniform brown color. We don't like anything that's pitch black, that is multicolored brown, has kind of irregular areas of white inside. We don't like anything that's red or blue. So you can see that lesion right there that they're talking about, the color is irregular. It's multicolored. The next criteria we use is D for diameter. Is it larger than the head of a pencil eraser, or 6 millimeters? Okay. We like things that are small. If you come to me and something is weird and it's 1 millimeter, hey, it's better to get it off when it's smaller rather than when it's bigger. So this is kind of a loose criteria. And D ties in with diameter, ties in with evolution, meaning is it changing? Okay, so if you're noticing that you have a mole that's changing, I'd want to see you for it. And I try to listen when people tell me something's changing, and I will sometimes, even if I'm not particularly concerned about biopsy, because sometimes those things look funny. Sometimes melanomas look funny, and they don't meet all the typical criteria that we talk about. So anyway, but this is the most majority of what. So is it changing? Does it seem to get bigger over time? Melanomas evolve on a course of months rather than years, like basals. So if you're worried about something, let me know. Certainly people up until around age 40 can make new moles, and that's normal. I mean, they have to start sometime. But if you're over 40 and developing new moles, we don't like that. You shouldn't be getting new moles over 40. Okay, so let me just touch on a couple other normal moles. These are what we call intradermal nevi. These are the ones I was just talking about, like the sort of beauty marks that people have. And they can be darker, they can be just flesh colored, like these are here, or even pink. And then there's these kind of moles that kind of violate our rules, but they're fine. They are blue. They're called blue nevi. And these, the pigment is deeper in the dermis, so when the light hits it, it makes it appear blue rather than brown or dark. So, but often they can be confused with melanoma, and unless I'm 100% certain that's a blue nevus, then I'll biopsy them too. But even though they're benign, because they can mimic melanoma. Most common location for melanoma in females is the legs, number one, and then the upper back, number two. So those are areas that are, especially the back, is difficult to look at. But if you look at yourself in the mirror every few months and get to know your moles, okay? Get to know what's there so that you're kind of used to what's there. So if you're like, I don't know if that was there before, you just say, okay, I'll call Dr. Brooks or Dr. Sara and we'll take a look. So if the more you look at yourself, the more you can know what has been there before and be confident that, oh, that's been there forever, or this is changing. But it requires like a little bit of work on people's part to look at yourself. One thing I should say for AAD, they have this this little graphic thing that you can download, and it's like a map of your body so that you can kind of like map it out, your moles. I actually think taking a picture of your back with your smartphone in a well-lit area, well-focused, and obviously have somebody else take your picture of your back because you're not going to be able to do that. That is a good way to compare things with having an objective, picture in front of you where you can check over time. So that's always good. And I do, when I'm monitoring moles in the office or doing a biopsy, I always take a picture because it's easier than just a measurement. I mean, love pictures as dermatologists. So that's really helpful. So melanoma, again, so other pictures of and again, you can see how seborrheic keratoses could mimic a melanoma. I mean, they figure out how to get this thing away. You can see how they're really dark. They can be irregular and they just look very odd, and they can grow really fast. So that's always my favorite thing to tell people that, hey, it's not a melanoma, it's a seborrheic keratosis. So, that's pretty much all I wanted to say.
Yeah, well, that was great. Sorry, I interrupted you.
No, I was gonna say, any questions?
No, but we'll take a moment to let people submit questions if they have it. Maybe I get a lot of questions about dermatofibromas. Do you think you could maybe pull up a picture of one of those and
Sure.
Characteristics and
sure, just to not make anybody dizzy with what I.
Yeah, if people have questions, go ahead and submit them, and then we'll go through those. Oh, there was a question I forgot. Sorry, about skin tags too. So, what causes skin tags? Are they dangerous? How can you get rid of one? And then there was another question about rapidly growing skin tags.
So skin tags tend to happen in areas that rub together, like the armpits, eyelids, neck, buttocks, groin area. They are not pretty, but generally benign and they usually don't cause people any trouble. However, they can sometimes get larger and kind of hangy, and then people will shave over them and they'll bleed, or like they'll like start getting irritated when you exercise. And certainly, if that's the case, taking them off is very easy. We numb it up and we just snip it off. Sometimes it's just easier to just snip it off without numbing it up because they're both a pinch. Yeah, we snip them off, and then those ones will not grow back, but you will probably get more. Why do they happen? Well, they happen because the skin's response to chronic rubbing is to thicken, and that's why we have calluses and things, but one of the ways it does that, certainly weight gain, when things are rubbing together more, people are more prone to getting skin tags. So that's one reason that it happens. And yeah, that's basically the main thing is obesity.
Okay. Actually, we have a few questions here. So, how do you examine your head through hair? And is there something classic to look for?
Yeah, so that's difficult. The what I do, because I'm looking up and over, is I just sort of separate the hair, look, take it, separate, just look like that. I mean, skin cancer on the scalp looks the same as skin cancer anywhere else. The problem is that you're looking through hair, so you don't always see it. And melanoma is flat in general. It's only raised about 15% of the time. It's nodular. The rest is flat when it first starts. So yeah, that's difficult. You basically have your significant other or friend take a look. You can try to do your best to sort of look in the mirror, handheld mirror. But yeah, you're looking for any bump, slow growing bump, rapidly growing bump, and then for melanoma, it's generally flat. So yeah, it's scary. Here comes a child.
Um, a question here about lipomas. Maybe just briefly describe what that is. And then the question is, are lipomas benign?
So yeah, so lipomas are 99 times out of 100 benign. There are cancerous forms of lipomas. So if you have something that you feel like is a lipoma, but it's growing fast or hurting, that can be a symptom of a malignant lipoma. But there's also angiolipomas, which are blood vessel-y, and they can be painful too. But generally, lipoma is going to be sort of feel like smushy. Very common location is the upper back for them, although they can occur anywhere. But the bottom line is that if you feel like something is growing or changing, let us know so that we can at least measure it, have it on file, and then watch it over time.
Okay. And then can you elaborate more on moles after 40 years old?
Sure. So generally the cutoff time when you shouldn't be making any new moles is over 40. So and over 40 is you have a higher risk for melanoma anyway, because you've acquired 40 plus years of chronic sun exposure. So although not a hard and fast rule, that's sort of kind of a way we divide it up into saying, okay, I should really be paying more attention to this particular mole, because at this person's age, they're making a new mole. Most melanomas come from completely normal skin. Stop it. They come from completely normal skin. So only a third of melanomas come from moles that you already have. So 2/3 of melanomas, they come out of nowhere. So they're from a mole that you never had, and you're like, boom, oh wait, I didn't know I had this mole. So that's the 40 is kind of how we cut it off, but it's not actual.
Yeah, and then some question here on full body skin checks. I guess there's two separate questions from two separate people, but one is how often you should be getting a full body skin check if no history of skin cancer, and then if a history of skin cancer, uh, how often should you do a full body skin check?
Yeah. So if you have a history of skin cancer, it depends on the type of skin cancer. So basal cell, squamous cell, I see people every 6 months for the first 2 years, because they tend to occur in clusters. So so every 6 months for the first 2 years. After that, it's yearly. You bought yourself a yearly skin check. If you have a melanoma, the first year it's every 3 months. The second year it's every 4 months. The years 3, 4, and 5 it's every 6 months. Okay, so and then after 5 years, you're clear. It's once a year. Now there are people who have hundreds of nevi that don't fit exactly into that mold, and I see them more frequently, even though they've only had 2 melanomas or something. I'll see them every 6 months forever, because they just have so many moles. I feel more comfortable doing that. Or if people have like squamous cells, or they're constantly growing squamous cells, I'll see them back every 3 months, because I don't want to wait every 6 months, because they're just fertile fields for squamous cells.
Okay, so We have a bunch more questions that are coming in. Unfortunately, we don't have time to get to all of them because we have to get to our afternoon patients. But just a couple things. One is this session was recorded, and you can find all of our old webinars up on the Rockville Internal Medicine website if you go there and click on the COVID-related webinars. Friday, Dr. McConnon is our sleep doctor. He's going to talk about insomnia and COVID. And next week we have 3 more lectures, Monday, Wednesday, Friday, and the email will be going out either today or tomorrow, probably from Privia, to give you the information and the links. And then just one last question here, I think that we have time for Dr. Brooks, that I'm sure a lot of you are going through. Can you comment on skincare when we are washing our hands so frequently now and using items like Clorox wipes? My skin is drying and cracking. So I'm sure a lot of people are going through this.
So make sure that you're wearing gloves when you're like trying to wipe off surfaces. Like if you're just doing cleaning in the house, try to minimize your exposure to all the chemicals by wearing gloves. You can't always do that, but if you can, great. Use a more gentle soap, like without fragrances, or I like a Cetaphil gentle cleanser. It doesn't foam like a regular soap. Like you're not going to get that nice lather, and it's not going to smell yummy, but it's not going to be as irritating to your hands. Then when you are finished washing your hands, keep a tub of Vaseline or Aquaphor right by your sink, and then every time after you wash your hands, kind of pat it dry, and then put a thin layer of just Vaseline. And even like before you go to bed at night, taking a thick layer of Vaseline and putting it on before you go to bed, then you'll be pretty good when you wake up in the morning. And do that for a couple days, you'll be good. But the bottom line is non-fragrance soap, gentle cleanser, and Vaseline.
All right. Well, thank you. If anyone has any specific questions about things on their bodies, feel free to make a virtual appointment with Dr. Brooks or Dr. Sara Polly. As Dr. Brooks said, half her schedule has been cleared because they were routine skin exams, and we're not doing so many in-office visits. So she has time. If you have any questions, if you just want to chat about your family history and concerns, I'm sure she'd be happy to help you with any just anxious questions. And thank you, Dr. Brooks, for your talk.
Thank you. I miss everyone so much.
Showing us that doctors are real people, and we also are dealing with the struggles of home isolation and home offices. Thank you for the laugh from your thank you to everyone for tuning in, and let us know if you guys have comments or tips for future webinars. We'd love to try to cater to what you think you'd be interested in. But thank you again to Dr. Brooks, and I hope everyone has a wonderful afternoon.
Thank you. Bye.